No. No, I think I'm okay. So, first thing I want you to know is that 15 years ago, when I was presented with the concept of sacroiliac joint disease and sacroiliac joint fusion, my take on that was, I don't believe that. I don't see it. It's not there. I don't have the patient population for that. My practice has changed a lot since then. And more or less, this is the result of the data. I don't know how much time you want me to spend on that, because I can spend a whole week on that and it's still not be done. But if you look at it systematically, you take 100 patients in your practice with lower back pain. 22% of that it is not spine, it is the sacroiliac joint. And if the spine is the only thing you look at, you will miss them. These are the patients in the United States, literally, over the years, they go to surgeon, they are dismissed, they are labeled as pain seeker, as drug seeker, as people who pretend to have pain, and some of them become literally suicidal. I have seen those patients, I have treated those patients. As a matter of fact, these are the patients that they're like a nurse, that 4 weeks after the surgery go back to work, after they have been for years labeled drug seeker and so on. So included in your differential diagnosis, start looking for it. As a matter of fact, if patient had previous spine surgery, fusion, especially L455S1, and you have 100 patients with previous surgery that the pain didn't go away. This is again the data. 43% of them, it's not failed back syndrome, it's not something you did wrong, it's not drug seeker. It is truly a missed sacroiliac joint disease. And sacroiliac joint disease is nothing but adjacent segment 12-5S1. Please, if you don't take anything out of this talk, think about it as an adjacent segment 12-5S1. It is a very peculiar joint. As a matter of fact, it is the only time literally spine, the sacroiliac joint works is during the birthing process. Open up, like open book, or surgeons are more familiar with that, to open about 4 degrees the pelvic aperture for the birthing process. When I go to different place, and actually there's a joke I make. I put a crisp $100 bill on the table and I say, whoever calls a muscle that works on only as a sacroiliac joint, you get that $100 bill. And I'm happy to accommodate that today here as well. If you name a muscle that works on, like connect from one side of the sacroiliac joint to the other side, I give you a crisp $100 bill. It's a joke because that muscle doesn't exist. There are muscles that traverse the sacroiliac joint, but their action is not the sacroiliac joint. It is a non-functional joint. How do we know that? Number one, there is no muscle that goes across. Number two, it has so many variability in the joint that allows, because it's non-functional, even two sides of the same person look different. They're almost, I haven't, it's in so many variability in sacroiliac joint like no other joint. It is ligament, practically 2/3 of the weight is hanging on it. The maximum physiologic motion is 4 degrees, and that only during birthing process. As a matter of fact, they found out that literally there's an enzyme and comes and loosens the ligament, so the woman don't die during the surgery, during the birthing process. And more than that, we know that after birthing process, women have 7 times higher rate of sacroiliac joint disease and pain than other times. And for that reason as well, the age for sacroiliac joint disease is younger. In the birth aging group, especially women who work out and go for jogging, running, and so on, are more prone to that. For a long time, let's talk a little about the anatomy, okay? So, because for a long time, we approached the joint posteriorly from midline. And anatomy tells us why we should not do that. We are good, because most of the vessels, most of the nerves are anterior. The posterior nerves are minimal, and mostly, as you see here in the bottom picture, they are just have sensory nerves, and sometimes we actually burn them like a radio frequency ablation for pain control. The problem is they are like, contrary to medial branch block, they are very variable, and there are multiple of them. So medial branch blocks generally, especially so-called here, if you go and numb up this nerve, you are injecting ligamental part of the joint, not very successful. Again, this is a little more anatomy of the posterior approach. Pay attention to the nerves. You see they are mostly in the bottom third. This comes to your help, understanding this picture when you are doing the surgery, because you see that most of the nerves are in the bottom third of the pelvic area, whereas your approach is in the top part. Now, let's talk about anatomy, because the alphabet of surgery is anatomy. If you don't understand anatomy, everything else is irrelevant. Sacroiliac joint has two parts. The part that on the top you see, we call that the ligamentous part, and all those nerves that you saw previously are there. And the bottom part, we call it the boomerang, is the so-called cartilaginous part, where practically you have a resemblance of joint. Now let me show you this. Could you raise your hand if you're an orthopedic surgeon? Yeah, most of you. Neurosurgeons? Oh, half. Okay. No, this is for you, neurosurgeon, because our orthopedic surgeon know it already. This in any other joint would be a completely disastrous arthritic joint. But for sacroiliac joint, this is a normal joint. This is a normal sacroiliac joint. As a matter of fact, I had the privilege once to scrubbing with one of my ortho guys who did a hip replacement. Even that bad hip was the smoothest thing I have seen in human body. Whereas this is considered a normal sacroiliac joint. So for that reason, understand this. For that reason, just the appearance on the picture, MRI, CAT scan doesn't make the diagnosis, because you get 100 people, you get X-ray, CT, MRI. It looked like in any other joint, if you would see the same kind of picture you see in your visual view right now, you would say this is not a good joint, this is an arthritic joint, but that does not make the diagnosis. For that reason, the protocols are well established. You get images, but the images are to rule out other problems, not to rule in sacroiliac joint disease. So here, the patient population is younger, female rate. And here you see as well, again, systematically when you look at that, what is the distribution? What's causing pain in our lower back? Memorize this, because that sort of gives you a statistical understanding about how to deal with the patient you get. Okay, now I can tell you from my personal experience, since you see that it says 1/2 failed back syndrome is a side chain. This slide is 7 years old. I can tell that 2/3 of my failed back syndrome are sacroiliac joint disease. And the question is, if you're a spine surgeon and you don't have spine, you only do spine, you don't do sacroiliac joint, then you do a beautiful surgery. You did everything right. X-ray looks fine, CAT scan looks fine. Fusion is happening, but the patient has pain. That's all patient care about. They go to one of your colleagues who does take care of sacroiliac joint, and then they are the hero, not you. Even though you do the heavy lifting and cure your spine problem, but sacroiliac joint and lower spine, they have the same identical symptoms. I will come back to that, and you will understand that. So if you want, that your patient go to somebody else, and then the other surgeon probably say bad thing about you, how you did everything wrong, and do a sacroiliac joint fusion, and patient pain is gone. If you want to have that kind of practice, don't walk out of this room, because this is not for you. But if you want really a happy patient that will refer for years, personal experience, for years will refer the patient back to you, stay here, because you may learn something that really change your practice as it has changed mine. So let's go back. We call it chameleon joint. Why? Because It can pretend to be a facet disease. It can pretend to be a disc disease. It can have identical symptoms like lots of different problems. The pain can come down, sometimes can go up all the way to the rib cage. Say pain, you can have radiculopathy, and for a long time we did not understand why the patient with the sacroiliac joint should have radiculopathic pain, and films are not diagnostic. So look at that. This is, again, systematically view of the information. This is a pattern that along lots of patients of the pain that patient with the sacroiliac joint have. You can say this patient has radiculopathic anywhere from L3, 4, 5, even S1. They can have that, and for a long time we did not understand why. I want to ask somebody in the audio, audience here, like Sherman, why? I didn't understand that for a long time. Why a patient with a sacroiliac joint, I mean, I'm a neurosurgeon, you might have a better answer. Why a patient with a sacroiliac joint should have pain pattern like this? Anybody? Come on, you're a surgeon. You do the hip and knees. And you have seen patients with a hip and knee problem that the pain just radiates further down, right? So answer to that is actually anatomy again. Okay, let me go to my anatomical picture here. You see those nerves? Those are anywhere from L4, L5, L5, S1. All of those nerves have to pass over the sacroiliac joint. That pathological motion in the sacroiliac joint produces inflammation process. And the inflammation process is not contained to the joint itself. Like a capsule of the joint that becomes very painful, it can affect it. And this is an understanding that I didn't have until a few years back. So radiculopathy absolutely does not rule out sacroiliac joint, because that was for a while what we thought it does. So that, in the last 20 years, our information has come together and we have established truly diagnostic tools and diagnostic protocols, and literally protocol that insurance allow us to do the surgery. And we always in the United States insurances, but at the end of the day, they are sometimes keep us in line, keep us and help us to come with a path that is applicable to every patient. Okay? Certainly you have your history. Younger patient, spine is fine. You have taken your picture. Patient maybe minor trauma, just jumping from few feet. And you notice that sometimes this is another thing that I learned. For a long time, I was like, when I was especially young, I was relying only on the films to diagnose the patient. I quit touching the patient, but that's something that takes you back. I literally ask, stand up, open your back, show me where your pain is, show me. They put the finger within 1 inch or 2.5 centimeters of sacroiliac joint, meaning twice they point to the same place. We have a name for that, we call it 14 test. That is a huge hallmark, but for that, you literally have to ask the patient, and this is what I ask the patient, don't use your hand, don't use your finger, use your thumb. Put your thumb, no, don't put your finger, because then they just go around and so on. Put your thumb where your maximum pain is. If they twice put it within 2.5 centimeter or 1 inch of the same place, positive 14 test. Rule out other pathologies, obviously. Remember I told you 23% of the lower back, native lower back pain is sacroiliac joint. What does that mean? In 68% of it, spine. So that doesn't absolve you from doing your regular job. So, and this is the typical way of, as a matter of fact, I have a picture of that, and please go to my webpage, I'm happy to share it with you. I have a poster that has this picture on it, and sometimes patients come and say, this is my pain, this is how my pain looks like. Okay, so take a picture, take it from my webpage, put it on the wall, and let the patient help you, let be your partner in diagnostic. And you see as well, you know, that the minor fall, minor injury, especially in women, ask them about if they have given birth recently. These are all can help you for diagnostic purpose. So we talked about the 14 test. And I'm happy to share it with you. It's on my webpage. Sacroiliac joint is a very strong joint. And again, for half of you are neurosurgeon, and it's for us, this conversation is more for you than for orthopedic surgeon because they deal with that more often than we do. And you have to use literally the femur and pelvis to multiply your force on sacroiliac joint to diagnose it. And as a matter of fact, that is a problem. Can somebody help me to get a chair from there here, please? Can you help me to get a chair? And this is something that I want to make your practice easier. This is true in the United States. Probably won't apply to you, but it is the fact that the surgeon gets for spinal fusion 7 to 10 times more payment than for sacroiliac joint fusion. That is unfortunately a reason sacroiliac joint is tremendously neglected in the United States because surgeons get paid less. But then investigation of the sacroiliac joint is much more elaborate. So you have to spend more time to get paid less. And that put lots of patients, literally make them suicidal. Patients that say, I cannot do anything. My family sees me as a burden. I went to lots of surgeons and everybody says, there's nothing wrong with you. Okay? Now, let's talk about why am I saying that? Look at the amount of the test you need to do that. You need to do a Faber test. Practically, you see what the forces are applied. You have to do a distraction test. Again, patient have to know, this is not true. You have to get on the table and push on both sides. It is an elaborate test. And again, you see compression test. You see thigh truss base and how that aggravate the, do you want me to go back so you can take pictures? I'm happy to do that. So let me go back. So take pictures if you like, or I can share it from. So Faber test, distraction test, done. Next, compression test, thigh truss pain test. Now, and so-called Genselin test. That's the most complex one. So, if 3 of the tests plus 14 tests is positive, there is a sensitivity of over 75 to 80% sensitivity for sacroiliac joint disease. 3 plus Faber. But that takes time to do. And you do a lot of work to get paid less, no thank you, right? So we have developed in Arizona Society and my inspired spine practice what we call rapid combined provocation test. That is an entry point to do a quick test, knowing what you are going, and then maybe you send the patient to another doctor or to a physiotherapist or somebody else to do the full test for you. May I ask for your help, So, I'm going to speak louder here because I want to demonstrate to you the so-called rapid rapid combined sacroiliac provocation test. You're still in the phase of validation of this test. Yes, please. Thank you. And what? Thank you. And this is just to make the entry point easy so you can do it even in a busy practice. Please have a seat. So what is the idea of those tests? To literally use your femur as a like a fulcrum to aggravate your force on sacroiliac joint. And instead of literally, in many of our rooms, we don't even have a table. Then you're done, you know. So what I tell the patient is that, you know, first of all, what I'm going to do the Rashish might be painful. Please don't hit me back. Please sit comfortably. Then please put your ankle And already some people say, no, I cannot do that. I haven't been able to do that for years. And then you stabilize one ankle on the knee, and then you put your hand, you see I'm going to 3 times, 1, 2, and then for the last time I put the whole weight on that, and that combines the favor, canceling and fight trust in one, and it's, my take on that is pretty, if not as sensitive as 3 plus favor, because favor is doing very good thing. Okay, so I do it on both sides, and yeah, let's try that. Again, stabilize this. 1, 2, and then by the last time I put full weight, and obviously I stop. If any of them is positive, the idea is not giving patient pain, but the idea is to see if provocation of the joint causes pain. Okay, so, and it takes literally for both sides 30 seconds. And you don't have to get on the table and so on. It gives you an easy entry that it doesn't overwhelm your practice, that you have to spend 5 minutes just for the provocation test, especially if you don't have a bed and so on. Thank you, I appreciate that. So, since you look so good, I'm going to use this video on YouTube. So, and once this is positive, you are still not done. Number one, the conservative management is a mess. It's a hit and miss. But in some people it works. It's not unified. We don't know as of today. And if you want to write a paper about that with me, please contact me. But the conservative management is not really unified. You do physical therapy. Physical therapy is the same like the lower lumbar spine. You strengthen the muscle. You especially work on your psoas, gluteal muscle, posture, and so on and so forth. Belt and braces has not been very helpful. Radiofrequency ablation is 1/3 to 1/4 as helpful as radiofrequency ablation for medial branch. So it is not very helpful. But certainly, you should do all of that before you consider other things. You remember those small things? There are variability in that, and they are not localized. So that's why the radiofrequency ablation and injection, the ligamental, this is what it is. This is the ligamental injection. It's not as helpful. But now let's talk about diagnostic blocks. So, clinic, provocation test, diagnostic block. And take a picture of that because that in the United States is a must. Without that, the insurance just don't pay for your function. What it is that you have to do, it used to be 3 injections. In the last 4 years, insurance has reduced it to 2 injections because it works. And it has to be low volume. You don't put like 10 cc of local anesthetic and infiltrate everything. You put only 2-3 cc max in the ligamental, the boomerang part of the joint, and you confirm with contrast and imaging, either X-ray or CT, you confirm you were in the right place. Now you see down the bottom the traditional classic injection that the contrast goes along. Sometimes it doesn't look like that. But as long as, you know, I unfortunately don't have a picture of that. To do the right way. Even though it's to do the right way. Even though it's a low-risk procedure, low-risk injection, it is technically a difficult injection. What I do is sometimes, not sometimes, all the time, I don't use a spinal needle because it has a sharp edge and it gets caught in the corners. I use a Tui needle and I put a small little bend on the Tui needle, like in the front, like so I can direct it, and then you feel it. You feel that, you know, when you drop into the ligament, and but you know, sometimes look at this picture. This picture has 2 parts. One, you see the contrast along the boomerang. The other one, you see some capsular spread of the contrast. So I'm okay with just that part because that. Sometimes when you do that, though, if it's not completely like in the cartilaginous part, it takes few hours, sometimes even half a day, for really to kick in. And what is it? Temporary pain improvement. 75% pain relief for a short period of time. What is that short period of time? It's the same short period of time that you get the pain improvement when the dentist numbs it up. Now, you guys are tough people, but do the dentists always numb it up before they start drilling here? Do they do that? Yes, they do, because I'd say they always do. And that is what I tell to my patient. When the dentist numbs it up today, drill tomorrow, it won't help you. So just expect that long improvement. Now, when I do that, and I always recommend, then you are there, as well, for God's sake, put some steroid. Because then they say, this is what I hear. The pain goes from 8 to 2, but next day pain comes back even worse, because in that time frame that the pain was down, they start using it more, but then 4 or 5 days later, when the steroids start working, pain goes down again. That's the typical picture, and I see it all the time. Okay, so, but patients need to know, because if they don't know that, they say, oh, it didn't help at all. Oh, 3 days later, pain come back even worse. Because they expect for the pain to go away permanently. You need to let them know it's a temporary effect, and they need to log it, have a log book for that log for the pain, meaning that they write the pain down before the injection, and for every 2 hours after the injection, they log their pain right and left separately, and then you look at it. Why? Because I don't remember what I had yesterday for breakfast, and so patients always forget that short period of time, especially if they see you weeks or months later, okay? So do it per protocol, do it constantly, and do it with a pain log. But then this is what you see, okay? Now, this is I think if you take 2 things out of this talk, this should be one of them. And take a picture of it, and let me explain this chart to you. This is a randomized group of patients. One group were assigned to conservative management, the other group assigned to sacroiliac joint fusion. As you see, the sacroiliac joint fusion group, the pain dropped and stayed more or less down. The conservative therapy management, obviously with all other treatment, it didn't get better. It was, the difference was so big that after 6 months it was unethical to continue the conservative management. And then we see all those patients were transferred to the treatment group, and they replicated. They all replicated 6 months later the therapy group. I mean, that is evidence. That is the level of evidence that in medicine you should always strive to comply with. So let's talk about the surgical approach now. Now, you remember I showed you the neural structure. They are all in the bottom third of the pelvis. So this area was more or less free of major nerves. Now, look at this. This is the so-called superior gluteal artery. If you do the surgery right, it should not be in your way. But no, unfortunately, the Lord did not consult with me when he was making the people. He had made lots of variability in people, and it might be in your way, or one of the branches might variably be in your way, but it's not a typical thing. As a matter of fact, after having done this surgery 600 times, I had only 2 vascular problems, and that was, both of them were early on, and in one of them I know that I was lower than I ought to be, and only one of them required coiling of the pseudoaneurysm of the vessel. So, but have this picture in your mind when you are doing that. But let's come back to that if you do it right, this should not be a problem, okay? Now, the requirement for understanding the pictures. You start the surgery, let's go back to that. There are medial to lateral approach that you literally open up from like a spine surgery. You go and visualize the sacroiliac joint, and for people who have done that, orthopedic surgeons have done it more, it's a messy surgery. There are lots of ligament that it bleeds like hell, and you know, I hope I never have to do that ever again. But I have done it a lot when I do big surgeries and scoliosis surgeries. I go from T10 to S1. You really want to include the additional screws in the iliac crest or sacroiliac joint fusion. And for the last 3 years, the evidence are that you should do that. Okay. Now, But we know that surgery is very bloody, and as a matter of fact, some surgeons now, when they do long level fusion, they do a regular fusion and they literally fuse the sacroiliac at the same time because we know it can help in the long run. Stay tuned for that. In the next few years, you will hear lots of papers regarding that. But in the lateral to medial approach, you have to get a good lateral view of the pelvis. And this is how a good lateral view of the pelvis looks like. You have to pay attention to greater sciatic notch. You have to pay attention to so-called ala. And then it's good if you see the end plate of the S1, but mostly pay attention to greater sciatic notch and ala. And it is sometimes hard to overlap them in one picture, and take something that is best for both, meaning that they overall give you the anatomy of the pelvis. And unfortunately, again, because it's a non-functional joint, you may have literally that one sacroiliac joint on one side is very different than the other side, even in one person. Okay? So sometimes it's hard to overlap them, but let me show you how they look. Let me see if I have a picture of that. Now, if you go to my webpage, I have lots of pictures about how this look like when they are not overlapped. You literally see, you see that, you see two lines here. Sometimes you see those two lines are very separate from each other. As a matter of fact, if any question, make sure that they are very separated, that you see them they are separated, and then you move the, when I'm in the water, I will show you that you move that in two axes to align them. Then we make you understand. Now, this is probably something an ideal picture. Sometimes picture have lots of gas, lots of stool in the colon, and it really makes it difficult to understand the anatomy. So if you have any question, do a ball prep. Okay, don't you see lots of gas in the colon, and that sort of confuses the opening of the aperture or the greater sciatic notch and so on. If any question, now just do a ball prep and then so the ball are free and you see a good picture because you need that. You need that for this thing. You need to see that these two lines are aligned and these two lines, the ala, are aligned. This is not a must, but that helps you to understand that better. This is the so-called true lateral view of the sacroiliac joint. Now, then there are two other pictures that are standard, but especially we neurosurgeons have never seen that. They are not familiar with it. It is so-called the inlet view. Now, the inlet view is a true axial view of the sacrum, and that's the only place in the spine you can take a true axial view. As a matter of fact, in a true inlet view, if you have a cage in L5S1, you can see the cage exactly at 90 degrees. See, it's flipped. And the reason for that is truly an axial view of the sacrum. Now, there is an appropriate way, I remember that when I was starting that, to not forget, and we always, for some reason, we remember inappropriate phrases. You say inlet view is into the butt. Okay, that's the inlet view, into the butt. And I show you how the X-ray should look like for you to get the true inlet view. And what's important there, and I have videos in my YouTube channel that show you, but practically we know most of the spine in the sacrum is made of 5 segments. I mean, then we have the coccyx and so on, but sacrum is usually 5 segments, usually. You forget about the S4 and S5. Just concentrate on S1, S2, S3. As a matter of fact, 70 to 80% of the mass of the sacrum is S1 and S2. Okay, so, but then you see those 3 ridges of S1, S2, S3. You literally here, you see 3 lines. And then while you are bringing the X-ray machine down, and I'm in the ward, I show you how to do that. When you see those 3 lines, they are getting close together and then separate from each other. And you get a feeling for it after a few days that how to align those 3 lines, that the 3 becomes 1. That's another thing you remember. It's like almost one of those religious things. 3 become 1, the Trinity becomes 1. That 3 lines become 1, that's when you know you have a true inlet view of the sacrum. And then that is the so-called oblet view. The oblet view is a true AP view of the sacrum. what you need to see. And again, that is where the bowel prep comes in. In a clean bowel, no stool, no air in the colon, in a 2AP, you see a nice sacrum, and you see actually the S1 and S2. S3 is sometimes harder to see, but S1, S2, you see the S1 and S2 foramen. And again, you can imagine what the angle need to be to get that. Let me just go back here. I want to show you, I come back to this, okay? But I want to show you how the position of the C-arm looks like in a true inlet view, and how position looks like in the true outlet view. And I hope this makes sense to you now, why outlet view is a true acute view of the sacrum, and inlet view is a true axial view of the sacrum, okay? I'll come back to that in a few minutes. And then we have lots of brochures and so on that visualize all of that. I'll share them all with you. So let's go back here. So again, my experience, I started with plugs. And you have all the information to know. For the same size, a plug, like a nail, is 2.5 times bigger than a screw. So that's why I moved to screws. And I used screws. I used like 6, 7 different kinds of screws. And then I always noted that bigger screws are better. Screws with cavity inside are better. Screws with more windows in the screws better, because that grows into that, and especially we use titanium, obviously. Bone grows into titanium, and titanium becomes part of your fusion. It has been even some confusion among our societies and so on. If fusion really needs to happen, because this patient gets better, even if you don't see any sign of fusion. That is almost magic. And so some people say, oh, you don't need a fusion, you just need to scan us. I do believe we need a fusion. Just that if you don't, our body is a very economic machine. It's economic magic. Our body is a magic. Whoever made us did a good job overall. Okay? Meaning that it just grows the bone as much as it needs, and then it stops. And that means that we get those patients that are doing great. You don't see any fusion outside, but the fusion from the bone to the screw was enough, in my opinion. I have no evidence to prove that, but that's why I think that even in those cases that you don't see a clear sign of fusion like a normal joint, you still see improvement of the patient, because bone and the metal become one, part of the fusion. And once it's stable enough, your body stops growing. That's the magic of our body that they come out. So this is again another so-called true lateral view. You see the two lines, and in this case, sometimes you see that it's sometimes too hard to make both static notch and the ala align. But then here you see with some motion they align. Now, this is the step of the surgery. You will see that when I'm doing the surgery. First, I draw the border of the sacrum on the skin, because when I'm looking at the patient, then I know what the orientation of the sacroiliac joint is. And I draw that line. You see that? This is the orientation. Then I know what my inlet view should look like, what my outlet view should look like. And understandably, from inlet to outlet is not 90 degrees, because sacrum is not flat, it's a wedge. It's usually 60, maximum 65 degrees, because sacrum is 25, 30 degrees. So that motion, and I always do the motion myself, I don't rely on the X-ray tape, they open the joint and I adjust it, and that really helps to be efficient. Then I connect the so-called promontorium to the middle of the sciatic notch. The promontorium, as you know, is the superior posterior part of the sacrum, and I connect the line that connect that to middle of the sciatic notch. That sort of gives me a good understanding about the anatomy. The shadow of the sacrum on the skin and the connection between promontorium and the middle of the sciatic notch. And I draw those lines. And these are those lines that you see, sacrum and line that connects promontorium to the middle of the sciatic notch. More or less, entry to the skin is the middle of the sciatic notch. Now, let's go back a few two steps. You remember we talked about there is a medial to lateral fusion method for the sacroiliac joint, and there's a lateral to medial minimally invasive approach for the sacroiliac joint. Now let me elaborate on that. There are two ways to do that lateral to medial. True lateral to medial. This is not one of them. But you can do that. As a matter of fact, you can take your orthopedic screw and put that there, and it works. But this method, the efficiency of this method is the perpendicular lateral to medial, perpendicular to the sacroiliac joint. Because you understand, sacroiliac joint has its own angle. It's not a true lateral to medial. Like imagine if patient's head is there, legs are there, sacroiliac joint is not like that. It is like that at this angle. So, and it is no different than just you have a pen. Anybody has a pen? So, if I may now visualize that for you, since the sacroiliac joint is an angle, my screws are like this, truly perpendicular to the sacroiliac joint. Whereas like the side bone and other things that truly go through lateral to medial, screws like that. Okay? So why is it important to me? Because imagine this is your screw. X-ray is here, it's in your way. It fights you. Whereas in my surgery, this is the angle, and X-ray is here. They are not interfering with each other, and that helped me to be more efficient in your work. As a matter of fact, hopefully you will see this is extremely efficient surgery once you are prepared. Like one of the reasons your surgery looks easy, Lauren, because you are prepared. You don't start guessing in the surgery what you want to do. You set up the system as that every element helps the other element. They are not fighting each other. Okay? So, and this is my method. It's not a true lateral to medial, it's a lateral to medial perpendicular to the sacroiliac joint. So, let's go next. The entry to the skin is the middle of the sciatic notch. And the map how that works, that when you are on the bone, on the iliac crest, you have to do just 1 to 2 millimeters anterior to the border of the sacrum. And that enables you, once you pass the iliac crest, you are centered on the sacroiliac joint. And depending on what system you use, I'm going to show you one system, and I'm really proud that it's now available in India. And which makes me a lot more efficient, but it doesn't really matter what you use. Use any screw with big holes in it. But you do that, you have to put obviously more than one screw, because one screw still can rotate. You have to put at least 2 or 3 screws to take care of the rotation. Again, ortho guys, it just comes natural to them. But for us neurosurgeons, we are not trained of mechanical stabilization like that. So either way, if you're going to use multiple screws, use the so-called the rudimentary S1, S2 as your border and put screws below and above. But if you use the trident, the system I'm going to, or Sacronova, which is now available here, if you're going to use that, use this, actually aim for the S1, S2, or aim for the S1 intended to the iliac crest, is exactly S1, S2, and then come back and I'll give you how it looks like, okay? So, let's just move to so-called that inlet view. In the inlet view, you are aiming for the center of the sacrum. That's all what you are doing. You have to see, you have to get a good understanding to adjust it in a way that as a matter of fact, in my early cases, or when I teach to other people, I ask somebody to go and put a small little string. I am on this iliac crest, and they put a small string, and they show me that I go to the middle of the sacrum. But then, in the outlet view, aim at or maybe slightly above the S1 foramen. Why? Because you want to be centered on the center of the mass of the sacrum. And about 50% of the mass of the sacrum is S1, and S2, S3, everything else is just less than 50%. Okay, so by putting the mass on the center of the sacrum, mechanically that is a more stable construct. Now, again, you can use any system you use, but generally you should use more than one screw. These are different kind of screws I have used, and today I'm going to use the so-called Sacroiliac system. Is that the name? The Sacroiliac screw? And what it enables me that, now the idea is you go to prosthetic lateral, and you go to inlet and outlet, and you put your screw, and then you can, if you are going to use a different system, then you go back and start all over again. And then if you are going to put a third screw, you do it all over again. But with this system, what I like about that, you put, and in all those other systems I have worked with, you put a wire, you then add a broach or drill, and as a matter of fact, sometimes home is really hard, sometimes you have to broach or drill multiple steps, then you tap, then you put the screw in here, you literally put the guide wire, and then you put the screw in and you start turning. That's all you do. You put the screw in, it makes its own, it's a self-tapping, self-drilling, and then you see those two windows here. In the inlet view, you align those windows along the axis of the sacrum in the inlet view, and then there's another kind of out broach that open up the bone for you, and then you put the other two screws in an angle that literally gives you along the axis of the sacrum those three screws. And this is our end product looks like. There are lots of subtleties in doing actually the surgery, but I will talk when we are doing the surgery, I'll talk to you about those steps. And then this is the last picture I want to show you. You remember we called it Sacroiliac cameo joint? You have another name for that. Literally you call it the miracle joint. Because I've never seen that with other things. It's not rarely, but with Sacroiliac joint, I do a surgery that literally 15 minutes. And 4 weeks later, these patients stand up and they hug me. Because for them, it did a miracle. Something that multiple spine surgeons, multiple places told them that nothing wrong with them, and they have to live with that, or they become real, and so on, or offer them spinal cord stimulation device or intrathecal pain pump. I do a 15-minute procedure, they're back to work within 2 months. They're off narcotics. I mean, narcotics are not a big deal here. That's a huge deal in the United States, and all it takes is a 15-minute procedure. And that's why I call it the Cinderella joint, because it's the fastest growing musculoskeletal procedure in the United States. And believe me, you will be here, you will be just a few years behind the development in the United States. It's a beautiful procedure that we have been neglecting and dismissing and so on. But once you start getting into that, your practice will really change, because those patients are the most loyal patient. Every single of them will send 5 to 10 patients within 2 or 3 years, because he's the person who helped me. He's the person who took finally my pain. Okay, now, let's come back to that. Patients are allowed to have more than one problem, and many of them do. They may have spine problem and sacroiliac problem, but because the symptoms are like serial, meaning that you have to fix them both to give them the relief. And the person who finished the job always get the credit, okay? Sometimes as well, I see patients that say I look at the old picture, it was nothing ever wrong with this L5S1. L5S1 was a little bad and so on, but they got the fusion there. Sometimes that can as well happen, but sometimes as well, there's nothing wrong. Yeah, they got the lower lumbar fusion, they needed that, but it wasn't their only problem, and patients are allowed to have more than one problem, okay? So I stop here. If you have a question, I'm happy to answer now, but otherwise, I should change that thing. We changed the name. So, but if you have any question, please, I'm happy to answer it now.
Would you ever want to do a lumbar fusion? Would you ever want to do a lumbar fusion and the SISA together in any case?
My experience and lots of other experience of other people show, except if you are going to be like a very big scoliosis surgery that you know it's going to put too much stress on the sacroiliac joint, fix the spine first, because lots of time the sacroiliac joint, not all the time, but a lot of time is secondary to unstable balance problem and so on. That when you fix the spine, actually sacroiliac joint get better. But always prepare the patient that you may need a surgery. So now, you remember we talked about that there's a good amount of evidence, and if you're going to do a humongous surgery, add something to sacroiliac joint, but my preference is not to do them at the same time. Especially because I send my patient home in 2-3 hours after the surgery. So I don't want to do the unnecessary much bigger surgery that we keep moving.
So my question is that when you fuse the joint, you're actually dealing with the intra portion. So what about the extra-articular portion? Because some of the pain comes from the ligaments.
I'm sorry, can you repeat what?
So when you fuse the joint, you're basically dealing with the intra-articular portion of the SI joint. Now there is an extra-articular portion where the ligaments come into the picture. Don't you think those patients actually get relieved also down the treatment?
So I can tell you the result statistic. And the statistic is that picture I put on. Here, this picture is the statistic of it, that it seems that extra-articular or ligamental inflammation part of the joint is because of that macro motion and instability of the joint. And within 4 weeks, 4 to 8 weeks actually, you see, it's not immediate. It takes a week or 2 or 3 for the pain to come stabilize. But it seems that once you immobilize the joint, that the inflammation goes down and that pain as well subsides. This is just a statistic.
So is there any stats that says that despite fusion there is still pain?
Oh yes, there are,
So,
medicine, nothing is 100%.
Yeah, so
there's lots of patients that you fuse the joint is good, you get even signs that bone is growing, outside of the screw and so on, and patients are still in pain. And I guess we haven't solved no problem in medicine we have solved for 100%. And those are, by the way, the patient that, this is one of our, we deal mostly with pain in the spine and sacroiliac joint. And those are always the loudest patient that, you help 1,000 patients, but then 5 patients in 1,000 is what, 0.5%? I think 99.5% is a very good result. But those 5 patients make your life to live in hell. Always it is.
McCormick actually published a paper in 2025. It's regarding the update of SI joint. He also emphasized more about binder that we are doing so many fusions, still those patients come. So yeah.
Thank you. Okay, well, thank you very much. I guess there's no more question. Thank you, but catch up with me, and I'm happy to talk about more subtleties. If you have more questions, I'll be here for a few days. And I see lots of thank you, Thomas, to come here, all the way from South Africa. This meeting has been long due, okay? So, but catch with me, and if you are from another country, now, who are, besides Dr. Thomas from South Africa, who comes from other countries? Okay, may I ask where you come from? Bangladesh. 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 Oh, and
Iraq.
Iraq. Excellent. Yeah, we did that before.
Yeah.
Okay, where are you coming from? No. Especially for those from your countries, you can be, sacroiliac joint is neglected. You can be the person who the most prominent person in your country. Take the information, start looking into that. It's not a difficult surgery. We need a learning curve for that, like anything else. But let me make it easy for you to go and be the most prominent sacroiliac joint surgeon in your country. Okay, catch up with me. Let me try to help you to bring this to your country, because humans are human. The anatomy is the same, the pathologies are the same. There's a lot of neglected people. If you have never heard of that, you're an accomplished spine surgeon. If you have never heard we are in a good crowd. It's just a neglected, it's a Cinderella, it's a chameleon joint, it's a body camera joint, okay? Okay, thank you very much, everybody, okay? Thank you.